Great, thanks KG, and good afternoon everybody. I want to do two things in my very short period of time this afternoon. The first is to present a few new country-specific projections of antimicrobial resistant rates in OECD and G20 countries, about 55 countries. We've done those projections. They're interesting simply because of the approach that we've used, which we think is an improvement on previous approaches. But then most of the time, I want to be talking about the cost effectiveness of different strategies for reducing AMR. And there we're using a dynamic stochastic microsimulation model that focuses on OECD and European Union countries. And it's just going to focus on human health. Eventually, we do hope to include the animal sector as well, but for the moment, we don't have it. And before I start, I have to acknowledge the European Commission provided about half the finance for the work that I'm doing, and the ECDC and the World Bank pretty much all the data behind it. Right, getting into it. The first thing I need to talk about, these projections of antimicrobial resistance rates. 2005 is the open circle, 2015 is the light blue, and 2030 the dark blue. This is based on 8 bug-drug combinations, the main bug-drug combinations where you find antimicrobial resistance. The way that we've done it is not to apply the same rate of increase across all countries, as you can see. What we've actually done is a bit of machine learning approach here. So what we've done is to impute the missing values for all the data and created lots of potential data sets. We then forecast the partial correlates of drug resistance, things like health spending, out-of-pocket spending, and so on, through to 2030, so we can make predictions about what will happen in the future. We then forecast the resistant rates using, for those who are into this sort of thing, an ensemble modeling, which means we've chosen 3 different ways of doing the modeling: mixed effects, linear regression, exponential smoothing, and a random forest. Basically, this is machine learning jargon that I'm spouting at you. Feel free to ignore it. The point being, it's supposed to give better, more reliable estimates than just using a single technique. And I think you can see that because we don't get similar patterns across countries. One of the disadvantages of using the machine learning approach, of course, is that it's so complicated. It's by definition a black box that I've created in doing this. And so it's virtually impossible to pick apart why some countries are doing better than others. Nevertheless, there's some clear conclusions that come out of that. Yes, trends are not the same across countries. Generally, it's going to be a big increase in resistance by about roughly a 25% increase between 2015 and 2030, though there are some countries you can see where there's a fall over there on the right-hand side of the graph. And it's not a direct one-to-one relationship between antibiotic use. There are some countries where we are predicting an increase in antibiotic use, but these other factors like GDP, out-of-pocket spending, and so on, are having an effect, and it will reduce resistance in those countries as well. That said, it is clear that those countries on the left-hand side of the graph are doing something much better than those on the right-hand side of the graph, and we need to learn from them. One other thing, just want to emphasize from this forecasting model is just the difference between first line, second line, and third line. In fact, at least in OECD countries, we're even predicting that there'll be a decline in resistance to first line, not in countries like India, China, and Russia, which is why when we just focus on the G20 countries, you see a different pattern. But the big increase, the big news there is in the projected increase in resistance to second and third line antibiotics. Not news, I don't think, to any of you, but nevertheless, I think it's a slightly more sophisticated way of documenting this than previously. I'll skip over that for reasons of time and move directly into now talking. What I really want to talk about is what we can actually say about cost effectiveness of attempts to actually reduce antimicrobial resistance. And here what we're doing, as I said, we've got a dynamic microsimulation model. So essentially what we do, we take the population, we look at the health states, the ones relevant for looking at antimicrobial resistance. And then we calculate the transition probabilities. So each year we calculate the chance that they might develop a disease that might be resistant, calculate the probability of it resistance, they calculate the impact on their health, a series of transition probabilities. And we do that each year, and we project forward to 2050. That's the baseline. And then what we do is that from the literature, we look at things that might affect those transition probabilities. And generally, we've relied here on Cochrane studies or very extensive evaluations that have been done. Change those probabilities, and that we can use them to, again, go forward to 2050 and calculate the impacts. So here's some of the results from doing that. These are averaging across all the countries that we're covering for those areas that I mentioned. Avoided deaths per year, you can see very large amounts from improved hand hygiene, but all of them are showing some sort of significant reduction in deaths. Of course, that's pretty typical. You find that in all sorts of studies. What I think where it gets more interesting is if we add the health expenditures, or rather the expenditures that you need to put into getting those results in terms of reduced mortality and morbidity, and you put them against the cost savings. And using Mukash's framework, these are only direct costs. In fact, they're only the hospital costs. We've not included any of the indirect costs in doing these calculations. There's a reason for that I won't go into now, but I can in the discussion. And what you can really see is for things like enhanced environmental hygiene, yes, you have some savings in healthcare expenditure, but there is also a significant implementation costs. So you can see there's savings, the red below the line, but also costs in implementing these strategies in the blue above the line. Over there on the right-hand side, things like delayed prescriptions and mass media campaigns cost very, very little and have very, very little in the way of savings. You can see immediately, of course, that improved hand hygiene costs virtually nothing, and there's significant savings. These are probabilistic estimates, which is why we've got the whiskers there as well, which means I think I can turn it into something which maybe is a bit more meaningful, which is the probability of these interventions being cost-saving or not. And remember, this is just talking about the hospital costs. It's not adding in any of the wider costs in terms of indirect costs or even wider costs in the health system, in the primary healthcare sector. This is just purely the hospital sector. And you can see when I look at improved hand hygiene, you're 95% certain if you introduce the model that has been included here, which is broadly the WHO 5 hand washing regime, and the evaluations that have been done on that, you're 95% certain to actually save money. There's a small chance that you might be unlucky and you'll still get something with a cost effectiveness ratio of less than $50,000 per daily, but nevertheless massively likely to be cost saving. Over there, the least attractive of all these options is the mass media campaign, when you have roughly a 50% chance that it will have a cost effectiveness ratio of less than $50,000 per daily, and then a roughly equal chance that it might be either cost saving, that's the blue at the bottom, or it might have a cost effectiveness ratio of more than 50,000, which is the green, a very small chance that it might be worse than doing nothing. This is what happens when you do probabilistic estimates. So basically what this is saying is that virtually anything that you want to do to reduce antimicrobial resistance that's ever been tried and evaluated is not only cost effective, it's probably cost saving. And that's just within the hospital sector. Okay, why did I just focus on the hospital sector? Somebody's got to pay for these things. The reason for focusing on the hospital sector is that even within the narrow silos that we do for health spending, somebody already has an incentive to actually do these things in order to reduce resistance. So the reason why it doesn't happen is, well, answers on a postcard. We always have to show something about the possibility of saving lots of lives. There's the chart about how many lives can be saved if you combine all those interventions in the way that I've talked about. How to finish in my last 1 second, I see that I have to wrap up here. Yes, antimicrobial resistance is increasing. You know that already. Projected increase in resistance to second and third line antibiotics is particularly concerning. Interventions to increase hygiene are very, show the most positive cost effectiveness effects. We can argue about whether they should be the priority because, of course, they're not really tackling some of the key determinants of AMR. Overall, public health interventions are cost-effective and very often cost-saving. And finally, combining them all together, and you can get even better results. Thank you very much.